Greetings, welcome. For those of you attending live, thanks so much for being here. Hello, hello. Welcome. Come on in, join in. It's nice to see some familiar faces. And because there is a ton to cover today, I'm just going to launch right into this. In any time you watch or register for any of these wellness webinars that we do every month, I definitely do not under deliver. I actually had to go through and kind of weed out some of the slides because I knew it was going to make me run over time. So thank you for those of you who are joining me live. Like I said, we always offer these monthly wellness webinars for free. People can register and attend live, or after the fact, which I'll explain in a second, they can watch the recording. And then a few months down the line, this also gets recorded and uploaded to our Dish with Dina YouTube channel. So thanks so much for being here. This month, we are going to talk about the science of weight. When we have the conversation around weight, especially in the way that I think the general population tends to engage in that discussion, it's usually about voluntary weight loss or weight management of some kind. And it's not your fault because we are bombarded all the time with messages around that, social constructs, television commercials, social media, etc. So I really hope that what you get out of today's discussion is a little bit different. Maybe you know some of this stuff already, maybe you don't. And of course, I'll introduce myself a little bit more formally in a second. But some of the takeaways that I hope that you get from today's webinar has to do with the following things. Let's learn a little bit more about the concept of our body composition and also dive a little deeper about how in the clinical setting, as far as healthcare is concerned, how we utilize weight. What do we do with that information? And also learn too about some of the underlying root causes that could potentially affect your weight, whether you want it to or not. As always, these sessions are recorded, which I'm assuming everybody heard when you got admitted in, that you hear the little ding dong bell, and that we're recording these sessions, as I mentioned, because a lot of times, whether you are on the East Coast like I am, or across the states, or out of the country, other places across the world, you might not physically on your schedule be able to attend these webinars live. So we usually get a bunch of people signing up and then a handful of people that actually show up live. And as I said, the recordings will go out after the fact for anybody who did not catch it, and for anybody who registered for it, you'll receive a recording link. And then in a couple of months, we also post these up to the Dish with Dina YouTube channel under the wellness webinar playlist, so you can always go back and check things out at any time. If you didn't get a chance to register for this and you're watching me share this with you in that recording section. Our chat box is open. I tend to kind of keep my eye on the chat, and sometimes I'll actually even ask questions over the course of our webinar. So you can always post questions, comments, or feedback, or answer questions in the chat box, and I'll jump in to see. But we also try to carve out a handful of minutes at the end of the webinar for any open Q&A. And it doesn't have to be related to just this topic. It could be really anything. But that said, I always like to make sure that I am disclaiming that while I am a registered dietitian, I'm not your dietitian. So please make sure that you're following appropriately any of the medical advice that you receive from your own independent healthcare providers, or you check in with them to get clearance on anything that you want to do differently if you are managing a chronic condition, etc. Not only, when you register, not only are you getting a recording to this link, but you are also being added to the Dish with Dina email list. So if you're new at this, if you're the first time watching one of these things, what I usually do is every month I send out an email blast. It's part of a newsletter. I try not to bombard anybody with too much stuff on a much more regular basis. So about once a month, we send out the email newsletters, and that goes out to the wider registration audience. And you can always obviously opt out and unsubscribe at any time. But if you do that, then you miss out on stuff like this. So you won't get access to certain things that come after the fact. All right. So what I don't think I've ever done before in any of our webinars, this is a sensitive topic. So while I'm going to do my best to speak about it in a sensitive manner, I do want to just also provide you with a trigger or a content warning that if you feel like you're a little uncomfortable talking about weight, we might talk a little bit too about some disordered eating patterns or some triggers. Obviously, feel free to walk away and keep yourself safe and protect yourself. Okay, my dears? So moving on to who I am, if we've never met before. Hello, I'm Dina D'Alessandro. I am a registered dietitian nutritionist. You sometimes hear those words used interchangeably. I work and live out of New York City, but I also work and live sometimes out of New Jersey and Ocean County. And of course, you can always find me in the virtual space as Dish with Dina. I also am very, very fortunate to have an adjunct lecture position over at the Lehman College in the Bronx, the campus in the Bronx, where I teach undergraduate and and graduate nutrition sciences, and I'm also the campus dietitian there at the Student Health Center. All the other stuff here, you can read a little bit more about me, or you can check out some of my other platforms on social media, etc., if you're interested in learning more. I wanted to first start off with just this discussion around, especially as dietitians, what your healthcare providers tend to do. So in the world of dietetics, we have a particular approach when we're working with our patients, and really what we're doing is prioritizing any at-risk factors that have to deal directly with malnutrition, and I'll define that a little bit later on in the presentation. So are people at risk for something? So sometimes we just do a screening, right? We ask people questions. What's a day in the life of you? Do you have access to food, et cetera, et cetera. And then over the course of our sessions that we meet for follow-up and check-ins, whether it's every week, once a month, every 6 months, once a year, many years in a row, we're really just checking in to see, are these patients responding to the courses of action, the treatments, the interventions that we're setting up for them, and also monitoring and evaluating all of that stuff too, because humans are very complex and complicated, and sometimes what works for somebody one time might not work for somebody another time. So we always make sure we're checking in and evaluating and comparing those things. So as an example, when I talk about prioritizing this thing about malnutrition or malnourishment, what I look at is the overall person and the factors that are involved in keeping them healthy or having good outcomes for them. So say, for example, I always tend to use chronic kidney disease because I'm very familiar with that. And we have somebody who is maybe at stage 3 chronic kidney disease. I'm more concerned helping that person manage that condition as to what kind of foods they have access to or what kind of foods they're eating, so not as to exacerbate their condition, make it worse, more than I am than, say, if they tell me they're not physically active. Like, my priority is going to be make sure you're eating the proper foods to support your health, and we'll worry about working out later on. So this is why, again, we take like a multifactorial approach and we try to piece together all of the things that help support people, and we do that through many assessments over and over as we meet with our patients and clients. The treatments too, like I just mentioned there too, about monitoring some treatments before I go into this next slide, we're talking about anything. That could be medicines, it could be interactions, drug-food interactions, it could be food intake. We'll talk a little bit too about macro and micronutrients in a bit, but really we're trying to either help somebody prevent something from happening, or manage a current condition as it is, or stop it from getting worse, slow the progression of something getting worse. So let's talk a little bit about this term of body composition. When you step on a scale and your meat sack is just standing on and allowing the gravitational pull of the earth to pull down, you get a number on that scale that may not mean anything, but what it's really indicative of is all the stuff that you see here in front of you. It's fat, it's muscle, it's fluids, it's bones and organs and blood. This is all the stuff that is composing you as a human person. And as a healthcare provider, we do sometimes take that into account as far as health correlations. And again, I'll go a little bit more into detail in the coming slides about that. So for those of you who know me from my Lehman College position, I teach I used to, I don't right now, but I teach nutrition throughout the life cycle. And one of the things that we talk about is how our body is naturally in a state of growth and development up till a certain age. And in the case of what you see here, bone density, how strong our bones are. We typically reach that maximum amount by age 30. And on the right-hand side, you see peak muscle mass. So our bodies are building and maintaining our muscle mass generally occurs between the ages of 20 and 30 or so. What that means is that once that age has been met, things start slowing down a little bit. Our body is naturally going through the process of wear and tear. So it is now dependent on us as humans to maintain all of that stuff to keep going. And again, we'll talk about how we do that in shortly. On the left-hand side, bone density is important because we want to make sure we're preventing things, and the strength of your bones, preventing things like osteoporosis, which is porous or things that can be easily broken. As far as your bones are concerned, fractures as we age are one of the most common causes of concern for people who lose their balance or trip over something, fall down, break a hip, break a leg, break an elbow, and it's really hard for them to recover from that. So it's really important that we focus on bone density. So I want to, if you feel like putting this in the chat right now, or if you're watching this as the recording later on, you can throw this into the comment. I want to do a little quick pop quiz. When you think of strong bones, what is the first thing or things that come to mind? What specifically, I guess, what vitamins or minerals come to mind when you hear the words bone density? Like, what's the stuff that helps you maintain your bone density? So I'll give you a sec if anybody wants to chime in with what comes to mind as far as vitamins or minerals are concerned in the bone density, keeping your bones nice and strong. So if you said, or if you thought, or if you wrote in the chat, calcium, yes, you are correct. And vitamin D, you are also correct. I'm going to go through a little bit of a rundown. I don't have it here on the screen, so I'll read it off to you. Calcium foods are very important, or the intake of calcium is very important to maintain and keep our bones nice and strong and healthy. Calcium foods, I'm sure you're probably aware of this, right? Dairy products like milk and cheese and yogurt, very important. Also can be found in soy products as well. Believe it or not, some of your vegetables or a lot of your vegetables also contain calcium, like broccoli and leafy greens. We also have fortification of foods as well. So it's possible you might have, say, orange juice that is fortified with calcium. Calcium is not something that naturally occurs in an orange, but the food manufacturers can add it to it just to make sure that as a whole society, we are getting the amount of proper nutrients that we need to sustain and maintain our health. Vitamin D, the top one here, the top source for vitamin D is the sun. You can stand outside for about 10 minutes and just get a little bit of sunlight on your skin. That helps with the processing and synthesization of vitamin D. You can also find vitamin D in some foods like fatty fish. That would be tuna, salmon, mackerel. You can also find it in egg yolks. And again, you can also find vitamin D fortified foods as well. We usually recommend, if you're going through supplements and stuff, that we always try to make sure you understand supplements is exactly that. It's in addition to what you're eating in whole foods. So we usually prioritize, or we always prioritize as best as you can, getting the whole foods option. And then if you need to add a little bit more as far as supplements are concerned, then go ahead and do so. People who are more at risk for issues when it comes to calcium or vitamin D could be people who are not often outdoors, whether they are housebound or they're living in a care home or unable to get outside. People who might wear clothes that cover them. So if you are abiding by certain religious laws, you might have to have your sleeves and face covered. So you might be, again, a little bit more at risk for having a vitamin D deficiency. People who have a dark pigmentation, it's a little hard for the sun to penetrate there. So again, we try to make sure they're getting enough food and or supplementation to make sure that they're getting the proper amount of vitamin D in their food. If you already have osteoporosis or you are in your menopausal stages of life, because estrogen is a factor that protects our bones as well. And so naturally, after that starts decreasing in that life cycle, we start losing the bone density there too. Vegans. So if you're 100% plant-based, you're not eating any kind of animal foods. Like I said before, there are definitely some sources that you can get calcium from in the plant world, but they're a little bit less what we call bioavailable. So you might be able to, or I should say, you might be required or recommended to mix and match a lot of foods like sesame seeds and fortified foods as well that have vitamin D or calcium to them. Any things like green leafy vegetables, etc. Those are always good sources too. On the right-hand side, we talk a little bit about muscle mass, and that's important to maintain our muscle because it really helps us with maintaining our overall mobility. There also is a role there for metabolic health and strength that we have, right? We want to make sure that we're keeping ourselves strong and able to stay upright and be able to move around. Now, I do want to say, obviously, if people have physical disabilities or limitations or are maybe using assistive devices, like they're in wheelchairs or canes or crutches, then obviously those would be things that they would work with their doctor or their therapists in order to make sure that they're getting that movement and they're not losing any of that mass there. As we grow older, yes, it is true. As we age, things start shifting around. It's just natural progression of life, how things in our body, that we start seeing a higher accumulation of body fat. And we'll talk a little bit about that in a second, while the muscle mass and the bone density tends to decrease, which is what I was just saying before. So that is just a natural state of life. And this is why when it comes to research studies, we start looking more. So yes, bone density is for sure still prevalent, but we really do start looking more around that excess body fat and also making sure that we're managing our adequate muscle mass amounts in our bodies. Because like you see here, if we are carrying excess fat mass around what's known as the viscera, the visceral organs. It's kind of like in your abdominal area. So we're talking about the legs, the lungs, the heart, the abdomen area, your GI system as well can be affected. Again, I want to disclaim this also just by saying correlation doesn't equal causation, meaning that we just see that things can put you at a higher risk, but we'll talk shortly about how life and health is multifactorial. It's not just one thing will equal that bad thing to happen, but it does put you a little bit more at a higher increase of issues like heart disease, type 2 diabetes, and even some cancers as well. And as far as the muscle mass, so now let's think about muscle. If you want to put this in the chat too, a little quick pop quiz on this as well. What comes to mind when you think about whatever foods or habits that help you with maintaining your overall muscle mass? I'll give you a sec to pop that into the chat if you want to. And for those of you who are watching the recording, again, you can put this in the comment section. If you said protein, and if you said strength training or weight training, you are correct. The amount of protein that we ingest helps with repairing and maintaining our overall muscle mass, and also doing some sort of resistance training, whether it's body weight, whether it's dumbbells or barbells or planks or anything, wall push-ups, that sort of thing, lifting cans over our heads, doing something like that really helps with maintaining adequate muscle mass. So understanding body composition as a whole, like I said, can be really useful in the healthcare world. And again, we try to take into account all different factors. So it's not just about getting you to stand on a scale. What you see in front of you here are some alternate ways of how in a more clinical setting, we might be weighing and measuring you. So sometimes if people are chair-bound or if they are more frail, we might do what's called a mid-upper arm circumference, where we just measure the outside around the midpoint of their arm, like where you have, you make a muscle in between your elbow and your shoulder. And that can give us an indication if there is an issue with muscle mass deterioration. We also do this thing called the BIA, the bioelectrical impedance analysis. But the thing I wanted to share most importantly here is this thing called the DEXA scan. I'm not going to even try to say the dual whatever, because I always mess it up. I trip over my words, but I'm going to share with you here that the DEXA scans are known in the industry, in the wellness world, in the health and wellness world, as the gold standard. And what that means is that they are the most accurate piece of equipment or data that we can get to make sure that we are getting all the information we need in order to determine and assess whether or not you are at risk for something. Yeah, exactly. Thank you for chiming in with the protein. Thank you. I just saw that. So some medical facilities, some hospitals, radiology centers, they will automatically come equipped with a DEXA scan as part of maybe the lab work or the testings, the diagnosis testing that they're doing when you are admitting into those facilities. But you can opt to also get one of these on your own if you want to. The only issue is that sometimes, usually, these things are out-of-pocket expenses. So even maybe if you get a referral from your doctor, they're not going to be very cheap to do. So you might want to check with your doctor, your healthcare provider, or any specialist that you're working with if you fall under some of these at-risk groups. So if you're a woman who is age 65 and older, again, assuming you're probably in the menopausal stage at that point, you might benefit from getting a DEXA scan. Or if you have had your menopause diagnosis already post-menopausal and you're under the age of 65, that could also be indicative of getting that done, because like I said before, lower estrogen is related to a decrease in bone density. Men age 70 or older, if you have a history of falls and fractures and your bones are already a little bit not so sturdy to begin with, and then if you have any condition or treatment that is affecting bone health. So those are things like rheumatoid arthritis, if you have chronic kidney disease, if you're taking medications like steroids, that can also impact bone density. So just like you would be taking any medicine, you're kind of going for blood tests to see if there's a side effect that is related to the medicines that you're taking. That might be why your doctor is sending you for a DEXA scan, or why you might want to inquire about one. I also want to share, not on this slide, I wanted to share too some additional risk factors that can put you at risk for bone density issues. So a family history of the disease, that's always an issue to keep in mind. If you are a smoker, a regular smoker, if you are an excessive alcohol user, or if you have low body weight, because like we said before, if we're correlating sort of body and fat mass and muscle mass, and you skew a little bit on the lower end, that could potentially mean that you have a lower muscle mass, and thereby we might want to make sure that your bones are being protected, and we get some insight into that. So I didn't have time in today's discussion to share with you all of the things that we use when it comes to the calculations that help keep you alive, right? So we want to make sure we have the calories that you need. If we want to give people energy, we like sharing that information. We want to keep people's bodies functioning. And then in the more clinical sense, keeping you alive. Like if you are recovering from surgery, if you are unable to chew or swallow, we might need to give you a tube feeding. And we utilize calculations to make sure we understand how many calories your body needs just to maintain its overall function and capabilities. If you remember a few months back, I think we did the macros, micros, and food groups webinar, and that is available currently on the YouTube channel too. So you can always go check that out if you want to learn a little bit more about the unique needs calorically of individuals. But here, what I wanted to share with you is one of the things we use as a component of that calculation is understanding people's body weight. When I share things like this with you, these are recommendations and guidelines, and this is the textbook stuff that I, as a dietitian or people in the health and wellness world, will probably be learning. And I share this with you because I want you to keep in mind what some of your doctors or your care providers might be using when they talk to you about weight. One of our earliest methods here back in 1964 is this thing called the Hamwi method. Whenever you see the word, it's usually based on a doctor who discovered it or invented it. And again, this is a quote unquote ideal body weight. So I kind of challenge that because, again, what we're looking at and what we just said before with the body composition, so many factors come into play. So I'm sharing with you here a couple of examples of when we utilize this particular formula. For males, we use 106 pounds for the first 5 feet plus 6 pounds for each inch over that height. So as an example, I have a 6-foot tall male. So if I plug in that calculation, ideally, this person should weigh 178 pounds. Same thing with the female example listed here too. For females, we use 100 pounds for the first 5 feet plus 5 pounds for each additional inch over the 5 feet. So if I'm using a 5-foot 5-inch tall female, plug in the calculation there, that comes out to about 125 pounds. That is quote unquote ideal. If we see the person is a little bit skewing on a smaller frame or a larger frame, then we would either subtract or add 10% to that number there accordingly. But my friends, this is where I have trouble with stuff like this because, again, this is an ideal, and humans are not ideal, right? We're not perfect in that way. And I can even share with you, I can disclose, I am a 5-foot, almost 5 feet 4 inches myself. I am probably hovering around 140 pounds for like the last 20 years. So my weight has been pretty stable. So if I'm going to talk to my doctor and they're constantly telling me, I need to be more around 115, 120, 125 pounds, I haven't seen that number since I was like 11 years old. So that is not realistic for me to take into account. And this is why I'm going to continue sharing with you over the course of this discussion that it's really about the rest of the stuff that we're looking at. And that if you are not meeting an ideal, you shouldn't be forced to have to meet that ideal because it might very well be unrealistic and unsustainable. All right, so let me show you the metric version of this too. So as a comparison, a couple of maybe pounds, a little bit different, but I converted everything in my previous examples into the metric method, which is the Hammond method. And again, it's about the same amount of weight for both the male and female, again, just as an example. So just important to, kind of see what things are being used so that you understand why and what information might be shared with you at the doctor's office. This is why it is important to make sure that we're recognizing that humans need to be assessed individually. And I will also acknowledge that not every doctor, not every patient visit has the luxury for everybody to be able to sit and chat with each other for an hour or an hour and a half. Sometimes it's very quick, 15-minute check-ins and off you go. But when we use these equations, we should use those things as references or guidelines or recommendations, but really take into account the other stuff that you see here, the factors that are influenced by genetics, by metabolism, by environment, by psychology, and that globally speaking, we also have cultural preferences too. So I remember in some of the stuff that I was looking at when I was teaching, we did cultural foods, food society and health back in one of the 200 levels classes that I was teaching, where we talked a lot about this. And thank goodness the Leaving College community is very diverse. So I got a lot of feedback from the students who could confirm things like this. So as an example, somebody in Shanghai, right? Shanghai women are expected to be slim and slight and dainty because that to them equals feminine, right? Very feminine and demure. In comparison, if you compare this to something like in Jamaica, where having more quote unquote meat on the bones is a symbol of wealth and power and fertility. It means that you have money to feed yourself and you must be really robust. So just like we've talked in the past with some of the discussions around cultural traditional foods and meals, body size and weight are also really connected to identity of those cultures. And this is also why, again, I encourage healthcare providers and also patients, general populations, to make sure we're having these really sensitive, don't force anybody to fit into a construct that they don't necessarily feel comfortable in and then take away the identity from them. So the next two slides I want to share with you kind of in, again, how in healthcare settings, the way that we collect this information and what we do with it. So what you see on screen here from left to right is just a chart of the categories when we are working with children. And technically pediatrics spans the ages of 0 to 20 years old. So we plot our visits with these patients on a growth chart. And what we're doing there is we're looking to see if a proper trajectory is being followed, and then we would categorize the people accordingly. And we'll talk a little bit more about this too. So here, what we're looking for is that there's no very harsh dips or spikes. Obviously, we know some children might have growth spurts, and that's totally fine. But if we're looking at the patterns of things, that could be an indication that we need to address something that is more at risk for what I mentioned before with malnutrition. Or there might be some cognitive or motor skill issues there that are not functioning properly, and this is what we use that information for there. In the adult world, now we transfer over to what is known as the body mass index. This is probably something a lot of you are very familiar with and what the classifications there are. Here, I'm going to go off a little bit on a tangent, so please bear with me and be patient with me as I share a lot of information. As usual, I tend to have a lot of notes in front of me just to keep my mind on track here. So if you see me looking down, I'm scribbling things as I'm talking. The BMI is listed there. It is only based on the height and the weight of a person. So we just mentioned all the things that make up body composition don't get accounted for. It's just literally stand on a scale. How tall are you? Nothing else gets taken into account. And then boom, you're categorized as one of those classifications there. Now, it also, right, so it doesn't take into account things like fat mass or muscle mass or anything like that. It is also a very dated and very, unfortunately, a very flawed measure. It doesn't account for body composition, like I just mentioned, ethnicity, sex, race, age, and in fact, if you are working with or if you are part of the older adult population, what we've seen in research is people who are 65 years and older usually tend to have better health comes when they are at that overweight BMI. So as a healthcare provider, if I'm going into a patient's chart and I'm reading through the height, the weight, and I'm doing a calculation or the calculation is done for me that they are being categorized as overweight BMI, but they are already over the age of 65, I don't necessarily classify that as overweight. To me, that is kind of skewed now into the normal classification because again, as we age, we naturally start decreasing a lot of that muscle mass and that bone density. And because you're just basing BMI on weight and height, that's not taking that stuff into account. So we purposely kind of skew it up. I'm not going to go into detail in this, but yes, as a lot of things unfortunately are, BMI is originally rooted in eugenics. It is invented by somebody who is not at all affiliated with the healthcare world. And so you might be wondering, why? Why then is it very widely used as kind of like the end all be all in the medical community? Well, because it's an inexpensive and quick way to get kind of a snapshot of something. And as I mentioned before, I acknowledge that not every healthcare provider, A, is aware of that, B, has the time to spend with their patients in order to get a more nuanced insight into your overall health and your overall wellness and really be able to determine whether or not this has anything to do with that. So like we said before, alternative ways of measurement like height, waist circumference or the impedance or the DEXA scans could help provide that into a little better insight there. I also want to share with you too, and by the way, I just realized this picture, depending on how you're viewing it, the people on the top there, they're not naked. They have a pinkish colored bikini on, so I apologize if you think that looks like a topless person. It is not. And the people on the bottom there have a blue kind of like Speedo or bikini. So let's talk about this word obesity. Again, this is one of those words that people tend to be really up in arms about. It is classified as a disease in the medical profession, but we just got done saying it's also a category within the BMI, and the BMI isn't necessarily perfect. So how we define obesity is a variety of different things. We can either look at the BMI of a person and look at that category, and then this equals that. Or we can say there's an excess amount of body fat overall, 25%, more than 25%, or more than 30 for males and females, then that could indicate obesity as a classification. Or we can take a measurement around the waist circumference, and depending on the greater than inches there that you see there on the bottom, that could indicate obesity too. So yes, but again, maybe here's the problem with that. So if we take this back for a second and we look at the discussion around the BMI, this is kind of like a good visual representation as to what I'm talking about. You have different body shapes here, obviously, right? You have a sumo wrestler on the left-hand side and a competitive bodybuilder, I assume, on the right-hand side. They both weigh the same. They both are the same height, and their BMI technically is classified as obese. So if you're physically looking at the person on the left, you'd be like, yeah, I totally get that. But if you're looking at the person on the right, they don't meet any of that criteria, right? They don't meet the criteria of the BMI. They don't meet the classification. They don't probably have a waist circumference or body fat that we're concerning. So why are they classified as obese? So this again is why we have to make sure that we're taking a much more nuanced approach and view of our patients on an individual level. I will also say too, I'm hoping that you probably admit this, social constructs indicate that we're probably looking at the right-hand side and just automatically going, oh, that person's probably much more healthy than the person on the left. But I could argue both of these people are training for competitive, performance-based athletic sports in some way. So who's to say who's quote unquote healthier? And I could also argue based on research that people who are like the bodybuilder on the right-hand side maybe is taking steroids to bulk up their physique, but also because of the work that they're doing in building up their muscle so much and decreasing their fat mass so much that they have more issues with things like tendinitis and also issues with reproductive health, because we need a fair amount of body fat on us in order to help us with our hormones and make sure that our reproductive health is okay. All right, so let's get into this. I mentioned before that we were going to clarify or define this term of malnutrition. I think a lot of times people look at that word and they think of like skinny, emaciated kids outside of America who are, not eating properly, and that's the visual that you get. But really, mal just means poor or bad, and it can span the spectrum. So you could eat a significant amount of calories and get the amount of food that you need, but the calories might not be quality calories, so you might not be getting the amount of vitamins and minerals, so you're deficient in those things. Or you could be getting an inadequate amount of macronutrients, those are the calories like carbs and fats and proteins, and you're not able to perform. You can't function. Your body won't allow you to be in a state of wellness there. So this is, again, in the healthcare world, what we're really trying to assess, and why we continue to prioritize what is putting this person at risk. And again, you can always go back to the other webinar with the macros and the micros if you want to learn a little bit more about that. So let's talk about weight, and I'll acknowledge some things here too. Research-based evidence as a healthcare provider in this science space, I'm very much going to share with you the reviews of what we see in the science. And it's true, there can be the correlation of an increased risk of both chronic disease and also premature death. But you can see there, if we look just at BMI, that can happen to people on the lower end, or it can happen to the people on the higher end. And yet, correct me if I'm wrong, but I think a lot of our messaging out there that we see wherever we go is that the people on the lower end get kind of like applauded for being smaller, and the people on the higher end get shamed for doing so. So we're going to talk about that in a second too. The second point here shows that it doesn't have to be all or nothing. Sometimes we have what's known as a therapeutic area. So even if somebody is skewing on the higher end of the BMI or is overweight or carrying a lot of excess fat, They can decrease their body weight by about 5 to 10%, and that in effect will then help reduce their risk or get them out of kind of like the danger zone. But as I continue saying, as you can see in number 3 there, it is not always the only diagnostic tool that we should be using. And as I said before, we can't just assume that somebody in a thin or a smaller framed body is automatically metabolically healthy and someone in a larger size body or a fat person is automatically metabolically unhealthy. So let's talk a little bit here about weight bias. I'm reading my notes here. In 2016, there was about 1,000-ish so healthcare providers, doctors, nurses, who were surveyed, and about 40 to 50% of them did admit to holding some negative attitudes about people who are living in higher weight bodies. So this is known as weight bias, weight stigma, or weight discrimination. And what ends up happening there is, again, things just happen externally, right? When you're believing something, the outward way that you treat people, this is kind of unfair. And so this can end up having the patient spending less time in the session with the provider. There can also be less emotional rapport of developing that, support system that they need. And they could also be denied treatment, being refused things like elective surgeries, like knee replacement, until they lose the weight. So they have to wait longer to heal or feel better because they need to meet an ideal weight loss placed by their healthcare provider, or whatever related treatment or medical issues, or they might be denied certain diagnostic tests because their body is too big to even fit in the equipment. So again, there's no real accommodation being made around that. So like I was just saying, people in smaller size bodies, especially those who are, if you're looking at the BMI category of underweight, they are also at risk for chronic disease, and they are also at risk for things like premature death, but they'll probably get accolades for being smaller, or they'll probably get accolades if they've successfully lost weight from being in a bigger size body and now they're in a smaller one. Even though the steps that they took to get there might be extreme or restrictive, they'll still be applauded for that. So let's talk too a little bit about this. When people do try to intentionally change their body weight, they sometimes fall into the trap of what is known as weight cycling. So this is kind of commonly known as yo-yo dieting. That might be a term you've heard before. And this is the repeated cycle. I gotta get beach body ready. My daughter's getting married in October. Oh, I did a real bad job of eating over the holidays, so I'm gonna go on a diet. New year, new you, start of January, right? So this ends up where there's some unsuccessful, unrealistic, and unsustainable ways of managing people's health habits, whether it's food intake, whether it's excessive exercising. And again, they're focused on a quote unquote ideal weight that might not really be necessary or realistic, whether it's through their own pursuits, something that they physically want to pursue, or it's because unfortunately a lot of doctors do overprescribe weight loss as a means of treatment. So again, if you are wanting to lose weight, if you feel like you are not comfortable with your body image, I'm happy to support that. I also want to know the habits underneath it all, like what is it that you're doing, or if you need to gain weight because you had suffered some consequences and you're trying to add some pounds back on. Again, I'm looking to see how we can support, but I'm trying to make sure you're not going through these ebbs and flows and you're not focusing only on the number on the scale. Because when things like that do happen, we see a lot of times these things that can trigger people. There's negative self-talk, poor self-esteem, shame in whatever is either externally or internally being said to that person, the body dissatisfaction as well. And then ultimately, so if we are meeting with healthcare providers and our patients are listening to us say, you've got to lose weight in order to get this treatment, or oh, you packed on a few pounds since the last time I saw you. Now we're venturing into the disordered eating world, or eating disorders formally, and that is a real mental health situation consideration to be taken into account. Not a lot of doctors or healthcare providers are trained in how to manage people's mental health. So this is where, again, I'm trying to be really conscientious about the language that we use and how we can help empower and support our patients as well. So it's possible you've heard of this before. I'm going to introduce you, if not, to an approach called health at every size. And I always like to make sure I clarify it's not healthy at every size. We just got done saying we can't determine whether somebody is or is not healthy at any of the size. It's about health. It's about the common hopefully fair concept that everybody is given a chance, regardless of the body size that they show up in, to have access to quality healthcare and be treated in a fair and decent manner to remove bias from those constructs. So, a couple of things that I want to share around that. If you have felt comfortable, or I should say, felt uncomfortable being weighed in, because I think that's the normal sense, right? Like you walk into a doctor's office, they just weigh and measure you the second you walk in. So, if you are uncomfortable doing so, you do have the right to decline it. You can say, no, don't want to. I'm uncomfortable doing it. Or if they are a little bit argumentative, then your option is just to turn around and not face the scale or tell them, I'd really rather you not explain to me or tell me what the number is. It makes me uncomfortable. The provider can indicate that. They'll make a little note saying, patient declines to be weighed or patient prefers not to be weighed or they're uncomfortable to do it. That is totally your right. If you have the option to do this too, you can also see if you can work with a healthcare provider who uses more of a weight inclusive or a weight neutral approach. And as you can see there on the left-hand side, this is a little bit more patient-centered. There's that discussion about I believe you as the patient can tell me whether or not something is working. I also, if I'm working in a weight inclusive approach, I'm not focusing solely on the BMI or the measurements of any kind, or I'm not using weight loss as a health outcome. Again, we're coming up with different ideas and ways to help with supporting people in their wellness journey. Whereas on the right-hand side, this weight normative approach is pretty much all the other stuff that somebody is walking in with a cold or a broken knee, and the first thing that they're being talked to you about is their weight. So it's focusing on all of that. And again, that belief of the BMI correlates to poor health, which we know it's not. And I will share a critical examination of all the evidence that exists around these two approaches does not support the right-hand side. So here is where, again, I'm hoping that you can maybe get empowered if you do feel like this is an issue for you as a patient when you're working with your healthcare providers, or if you are part of the health and wellness field, you ease off a little bit on that and understand that, I tend to think of it as like lazy medicine when you're only focusing on somebody's weight all the time. There's so many other things that can support someone's health. All right, so that said, when is it necessary to get on a scale and get weighed? As you can see in front of you here, sometimes there are dosing issues if you're getting anesthesia or certain medicines. Yes, of course, monitoring the health of a pregnancy because a lot of different things happen, which you'll see in a second, that occur that we want to make sure the fetus is growing properly and the pregnancy is occurring in a healthy fashion. If you are dealing with eating disorder recovery, so if you're in an inpatient treatment program, odds are you're going to be weighed and measured there, depending on what end of the spectrum you are there too, of what's happening there. But again, uh, let me hold on one second. Let me take my little chat boxes out of the way, and I'll talk to you in a second about about like kidney and lung issues. So here's just an example of all the stuff that happens during the pregnancy of what determines that person's body composition, what all the things that are going on inside. So there is a natural progression of what we're looking at over the course of the pregnancy. And then here, if you are undergoing anything related to specifically heart failure, kidney issues, liver disease as well. If you're recovering from something like sepsis or burns, it might be medically necessary to treat you as well. It's possible you know this language already if you have heard of something called edema or ascites. Edema is like fluid buildup over the course of the body. It's usually prevalent in the ankles, like swollen ankles, swollen legs. Ascites is more in the abdomen area. And again, when that fluid builds up around those very important organs, that can be an indication of something even liver. So we want to make sure you're not getting that in your chest cavity or having any conditions that could put you at risk for things like heart disease, etc. All right, so non-clinical things. Changes in body weight, very normal, natural things that can occur sometimes here that you see in front of you, where you eat salty foods, between 2 to 4 pounds over the course of a day can totally happen. Sodium draws the fluids into the cells, and that is what is known as water retention. You can probably feel that when you're really parched, or for me, I get the shakes with it too sometimes. So salty foods can bring that intracellular fluid in, and then you step on a scale and you're 4 pounds heavier than you were the day before. And salty foods can appear in anything. We sometimes call them like, ultra processed foods, but cheese, bread, things that you use in your daily life, depending on the food manufacturer or the natural occurrence of the ingredients in there, can create that high sodium content. Excess calories in general, specifically carbohydrates, those can get packaged as to what is known as triglycerides, and that gets transferred into your body fat area too. So again, that could occur naturally too. If you drink a lot of alcohol, if you are dealing with hormone fluctuations or your menstrual cycle, you might see some fluctuations there too with weight too. Medications, side effects of medications can also affect your body weight, as can your bowel habits, right? If you're packed up and you haven't gone to the bathroom in a while, that's a weight. That's about 2 to 4 pounds of weight sitting in your gut there as well. On the other hand, you can also see changes in body weight if there is caloric restrictions or you're doing a fasting, or if you're exercising or you're sweating profusely, you'll see that water come out, and then you'll probably notice a difference in body weight as well. In the clinical sense, when we monitor this, this is stuff that we're taking note of if we over the course of so to compare very short amount of times, like 1 week, if you lose, X amount of percent from your starting weight to the end of the week is something else, that can be classified as a significant or severe change in body weight. And that's something that we would monitor in the more clinical setting. All right, so at the end of these, we are at the end. I'm sorry I didn't stop along the way to see if anybody had any questions. So let me just pop into the chat here. And as I said, there was so much stuff, so I felt like I was rushing through. So apologies also for that. But at the end of every webinar, I always say, pick a couple of things of what you think you might want to start doing, continue doing if you think you're doing things that are okay for you to keep doing, and then maybe things that you want to stop doing. I'm not sure exactly how well that applies to this discussion, other than if you are, like I said before, a patient who feels a little bit uncomfortable when you're working with your healthcare providers. So maybe you start looking for a new healthcare provider who uses a different approach, or maybe you're a caregiver who is always going with that person that you take to their doctor's appointments, and so maybe you want to inquire a little bit more or acknowledge, or have questions for them. That's something that you can start doing. Stop doing maybe things like, don't determine too much about your worth or your health as far as what the number on the scale is, and focus instead more on overall habits and other factors that potentially could affect either positively or negatively your health, and not just your weight, obviously. And then last but not least, if you have any questions, comments, or feedback right now from all of the things that I shared with you today, now is the time to chat, and feel free to drop anything into the comment section, and I'm happy to answer. It doesn't have to be just about this month's discussion. I always, this is the time where I also kind of pitch myself too. So the Dish with Dina brand is usually just me and sometimes a handful of student volunteers or some interns every now and then. We do a ton of work. Like, I think putting this whole thing together took me about 6 or 7 hours, believe it or not. Even though I know what I'm talking about, I want to make sure that I'm getting enough of the current research. And I really hope that you enjoy these things. So, it's free. I don't ask for money, but I do ask that you support me in other ways. Find and follow me on social media, subscribe to my YouTube channel, check me out on my podcast, share this stuff with people that you love, that you think might be interested in learning more about the things that we offer here. And then if you want to come back again next month, yay, March. Dietitian's favorite month. We have National Dietitian Day in March, and we also have National Nutrition Month. So the theme for National Nutrition Month this year is called Food Connects Us. So we're going to talk a little bit about behaviors and exposure to things and how we define foods in different cultures and ways of eating. And that will be held on also Thursday, March 13th from 12 to 1 p.m. Eastern Time. My friends, it's been fun sharing this information with you. I hope that you have taken away some insights, or at least feel a little bit more comfortable or confident the next time you go to a doctor's visit. Again, if you have any questions, comments, or feedback, feel free to drop them in the chat. Otherwise, I hope to see you again in our next session.